The information that we share today is from our own personal experiences and does not constitute medical advice. We do not endorse any products or services. Any said products or services mentioned on this podcast may not be suitable for you or your condition. Please consult with your physician if you have medical questions as it may pertain to your condition.
Hi, everyone. Welcome back to this week's episode on Take a Pain Check. Today, I have the privilege of talking to Dr. Ray Young. So hi, Dr. Young. Thank you so much for joining me today on the podcast. Can you start off by introducing yourself and tell me a little bit about your education journey and what you do for a living?
Yeah, sure. Thanks so much for having me on the podcast, Natasha. So I'm a pediatric rheumatologist, so basically a pediatrician who looks after kids with autoimmunity. And my particular interest is inflammation of the blood vessels and inflammation of the joints. So maybe a little bit about myself. I trained at the University of Toronto. And when I first started out, I actually wanted to be an astronaut. So my dream was really to do research and to try to answer difficult questions. And it's just amazing, right? The space and all of those things. And I still have that dream to be able to do research in zero gravity. But unfortunately, as you can see, I wear glasses, so I couldn't be a pilot or be an astronaut. So that changed my career a bit. And I went into medicine. And I was really inspired to go into medicine because I like people. And I also have a number of physicians in my family who really enjoyed doing what they did. They enjoyed looking after people, making people feel better, and really helping families along the way. And when you look at medicine, I also really like kids. In fact, being a pediatrician means it's almost like playing every day, as opposed to really the more serious dealings with adults. So combining the ability to help people in medicine, combining the ability to do research, and combining the ability to play with kids basically was kind of a perfect marriage of what I'm doing right now. So studying diseases that affect children and being able to look after them in the clinic.
Thank you so much for sharing that. I think it's so important for people to know the different types of physicians out there. And you did mention pediatric rheumatologists. So when did you kind of decide in your journey, like you want to do rheumatology, this is what you want to do?
Yeah, it's a great question. I had a very long journey, just to share that journey. So I think I took longer in university than people take going through high school. So I had 16 years of university before I ended up being a pediatric rheumatologist. So the one lesson I learned during this journey is that there isn't any wrong paths or steps you can make in a journey. And you really need to discover what you like. And if you like what you do, it might take a bit of a long time. You actually have enough training or enough experience to actually make that decision. So it took me a while to decide what I wanted to do. And it was actually after I became a pediatrician. And in fact, after I actually was working at the University of Toronto and at Sick Kids already as a general pediatrician, that I decided I needed to do more research and more training in order to improve our care or our treatments in children. There were lots of incredible discoveries that were happening in the lab, especially in genomics, especially in immunology. So actually, after I became a pediatrician, I went back to school and did a PhD. And it was actually during my PhD that I began to have a real interest in the immune system and why our immune system attacks our bodies, which is really the part of autoimmunity. Autoimmunity is really taken care of by rheumatologists. These are the physicians who actually look after when your immune system attacks various parts of your body. And it was during this journey, during my PhD, that I really uncovered that my real passion was in rheumatology. Kind of sealed the deal because almost every rheumatologist I met was nice. So it's nice to be able to think about not only the area of research you want to do, but also the colleagues that you're going to have as part of your academic family in the future. And these were incredibly nice people who didn't just look after one piece of the body. There are many areas in medicine where you just look after the heart, or you just look after the kidney, or you look after the skin. Whereas rheumatology really looks after every piece of your body. And I found that really appealing, that you can still be a whole person doctor and you can really marry that with your research interests. And that's really what drove me to pediatric rheumatology.
I know you kind of mentioned certain areas in the body. So for example, like hearts or like kidneys. I think a lot of the time people don't actually think of the major joints, your finger joint, and how much that can impact someone, even with their mobility and things like that. We usually think of, when we think of disease, we think of cancer, we think of diabetes, but we don't think of children getting arthritis or any rheumatic disease. When I was diagnosed, I didn't know what a rheumatic disease was. I didn't know kids get arthritis. I don't think anyone knew that. And so it's so great that you brought up that so many physicians out there that are working together and collaborating to make the future for kids with arthritis better, and with any condition, I'd say too.
No, absolutely. It's a whole big team, right? It's not just one doctor, it's multiple doctors, multiple physicians, multiple specialties, and multiple areas of expertise. So you're absolutely right, Natasha.
You said that you worked at Sick Kids, and that was kind of where you were at U of T, like University of Toronto. Were you always working at Sick Kids? Like, did you ever go to another hospital to practice? Was your life always in downtown Toronto?
So it's a great question. So after I did my pediatric training, and when I started thinking about research, I actually looked around everywhere, because what you want is you want to go train at the best place. And in fact, I was this close to actually going to the NIH in the US, really one of the beacons of research in the world. But when I went to the NIH, and at the guy that basically said, yeah, come on into my lab, I'll take you and all of that, what do you want to study? And I basically mentioned something to him. And he looked at me, he goes, well, why do you want to come to Washington? Why do you want to come to the NIH? The world expert in this particular cell that you're interested actually is in Toronto. And in my naivety or innocentness of not knowing that much about this area of research, just saying, but I was keen to basically learn about it, I had no idea that the world's expert was actually in my own backyard. So I journeyed back into Toronto, tail between your legs going, boy, they accepted me down there, but the world expert is in Toronto. I think I better find this world expert. Yeah. So just kind of lightly across town at the Ontario Cancer Institute, that I found this world expert, and I ended up going to this world experts lab and did my PhD there. So I was away, but the generosity of scientists basically sharing with you who is actually the best person in the world, if you really want to study that, brought me back home. So it was fascinating.
And it kind of worked out in the end too. Let's talk about research, because we've been talking about that throughout this conversation. When it comes to research, what do you primarily focus on in terms of research? Are there any specific areas of research that you work on a daily basis?
Yeah, so absolutely. And it's a very thematic what I do. So really, I guess a theme that captures it is precision medicine. So basically knowing on an individual level how to treat each patient according to their individual characteristics. So trying to decide when and in whom to start medicines, and when and in whom to stop medicines, and when and in whom to institute other management plans. So we're not all made the same, and one size doesn't fit all. And the whole concept of precision medicine is being able to find the exact fingerprint in a person so that we can really tailor treatment to that person. So in order to do that, you have to understand, at least in rheumatology, at a very, very molecular or cellular level. And I study the immune system, because the fingerprint in many rheumatic diseases actually happen to be based in the immune system. So we study the molecules and the genes and the cells of the immune system, what turns them on and what turns them off, and what unique kind of genomic signature it actually shows in each person, so that we can look at the signature and be able to tell how to personalize therapy and plans for each individual. And I started off with studying a disease called Kawasaki disease, which basically causes inflammation of the blood vessels, mainly the blood vessels around the heart. But the inflammation is kind of all over the body, but the kind of main target organ is these very important coronary arteries around the heart. And after studying Kawasaki disease, because it's a very kind of encapsulated disease, there are specific triggers, we recognized that we could take the lessons we learned in Kawasaki disease and also translate them and apply them to kids with arthritis. So there are kind of various areas, the two big areas now, studying this inflammation of blood vessels using Kawasaki disease as a model, and also studying kids with arthritis.
So you mentioned personalized medicine. That is so fascinating for patients living with any sort of condition, because we always think we're kind of trial and error. And I think in the doctor's office, we're like, oh, this medicine didn't work, that medicine didn't work. I've heard that there's a lot of genetic related testing that is prevalent in the States that some people do, but some people can't. I don't know. So many patients just talking to me about how they wish that they could find the medication that works for them. So I'd love to hear if you have any insight on what kind of is currently happening in that field? What is the progress up to date? What about genetic testing?
This is like the hot area in medicine, right? Not just in research. And it's hot in many areas and not just in rheumatology. But rheumatology is a very, very good example. And you brought up genetic testing. And we know in some forms of rheumatic disease, especially forms that happen in very, very young children, or forms that have very, very extreme presentations, like the disease is just a little bit different than the garden variety type of disease, that people have been finding genetic causes for these. And so there are often these change or mutation in a gene that can lead to a change in a pathway that can actually cause certain syndromes or certain diseases. And rheumatology is a really classic example. In fact, I would say that there's more than I can count on two hands, okay? New genes being discovered almost every year that are describing new illnesses in rheumatology. And what these discoveries tell us is that they can tell us not just about that one individual patient that has a very rare type of disease, but it points to, if you have one gene, the one gene plays a part in a very big pathway with lots of other players. So there could be 10, 20, 30 other genes that actually work with that gene. And it gives us a hint that maybe these 10, 20, 30 other genes that happen to be in the same pathway actually play a really important role in the garden variety, more common types of these particular diseases. And it's this type of research that leads us not just to look at genes or genetics, but to look at the products that these genes make. So genes make RNA, so DNA makes RNA, then RNA makes protein. And these proteins are within our cells, and they tell cells to do things. And it is this whole entire pathway that people are starting to dissect, so that the biomarkers or the fingerprint that you look at a person doesn't actually have to just be at the genes, okay, not just at the DNA, but you can find the proteins or the RNA that these genes are actually making that might actually give us a clue or give us a kind of almost like a red flag saying, this is the red flag that says, this is how I should treat your disease. And those have been incredibly exciting discoveries and really helped us in understanding and treating kids with rheumatic diseases.
In terms of what kind of availability of some of these things are these actually put into practice now that there are like testing for this and patients can undergo this? Or is it just, it's still being researched upon?
Again, one size doesn't fit all for each test. So it depends on how long the results have been discovered, because some of the longer discovered tests at the genetic level, completely in the clinic, you can actually order that test. We do that all the time. You order it, put it in the computer, and it gets done. And the sequencing and the testing at the genetic level can be done for our patients in the clinic, absolutely available in Canada. And some of the proteins that these genes make, absolutely, after testing, rigorous testing, it also goes into the clinic. But there usually is a very important testing validation step between a research finding and something that makes it into clinic. So it's not the same for every test. So some genetic tests are available, some genetic tests aren't, because some are research and some are clinical. Some protein tests are research and some protein tests are clinical. But absolutely, this technology is available, and this technology is available now for many diseases that we're talking about.
Yeah, thank you for sharing that. I think a lot of patients have probably heard of it, but don't have as much information as they wish they had to kind of approach their physicians with that. And I think a lot of people would benefit with just knowing that, you know, there is some light at the end of the tunnel, like there is a lot of research being done, and they can even look for that with the guidance of their like rheumatologist or any physician. So I wanted to kind of talk about COVID-19 because we're living through the pandemic right now. It's not ended. Mask mandates and stuff have been lifted. And I think a lot of immunocompromised people have an opinion to that. And a lot of physicians probably do as well. That's scary for us for sure. What is your kind of perspective on COVID-19 in general? So not specific to rheumatic diseases. How has that kind of affected healthcare and research? And maybe even some of the work that you're doing?
I think COVID-19 has touched every single one of us, not just in healthcare, but just every aspect of our life. Everybody in society has been touched by it. We would never have guessed 2 years ago that we'd be hitting the sixth wave right now in Canada, right? It's incredible what it's done. The impact on healthcare has been tremendous. So we've all had to take precautions to protect our patients and to protect the manpower to look after patients. So many kind of more elective procedures, as you've heard on the news and everywhere, has been put on hold. And I think that had quite a ripple effect on our society, so that unfortunately only the sickest right now receive care. Even the way that we give care, especially in rheumatology, everybody who has family members or themselves affected with this disease will know that sometimes it's not an emergency, but seeing a physician over the video is not a good substitute for seeing a physician in person. Because as a rheumatologist, and especially in arthritis, we're going to have to examine people. You can't just tell me what hurts. We need really a thoughtful, careful examination of people. Same with looking at blood vessels. Blood vessels are everywhere in the body. So we really need to have a look at everywhere in the body, listen, feel, examine, very, very carefully look to be able to make the appropriate diagnosis. So I think everybody has adapted and made really novel models of seeing kind of combined virtual care with in-person care, but one isn't a substitute for the other. And I think we're going to have to find a good kind of a good complementary model so that we can use the technology that's here to help us care for patients, and yet be able to combine that in a practical way with the real needs of being able to see people in person. I think that there's been a huge impact because of that. There's also been a huge impact because of many of the medicines that people have recognized need to be used in people with severe COVID-19 are the very same medicines that are used for our patients with rheumatic diseases. And this has actually led to really a shortage of these medicines and worries among our patients and patient families about whether they can get these medicines because they don't have COVID, but they are really dependent on getting these medications. And with the shortages, there's been some anxieties about getting these medications. And then lastly, but not least, is really effect on our patients who are on immunosuppressive agents. They worry very much about being able to mount a good protective immune response against COVID-19, and equally to have a good protective response when they get the vaccine. Because when you're on medications that suppress your immune system, it usually suppresses your immune system to not attack your own body, but it also suppresses your immune system to not mount a good immune response to a virus, somebody who's not supposed to be there, or a vaccine. So it's a little bit more complex, a little bit more nuanced for people with rheumatic diseases on immunosuppressive. So incredibly impactful because of that.
I know you brought up 3 really good points, and I kind of have follow-ups to all of those. So the first one that you mentioned was kind of medications that patients with rheumatic diseases have. Those medications are used to help with COVID-19. So would you be able to kind of give an example of that medication or what that is? I think some people were also just really confused personally with me when I was taking, for example, like Plaquenil. They were like, wait, but you use that for COVID, so why are you taking that for arthritis? Like there's a lot of talk, but no one really knows the real facts.
The bottom line is COVID, the virus itself probably isn't a horrible thing, but the immune response to the virus is actually the horrible thing. And that's the common denominator between COVID and rheumatic diseases, is that our immune response is activated. So one of the worst consequences of COVID-19 is very much like some of the worst responses we see in rheumatic disease. And it's something called cytokine storm syndrome. And it's gotten a lot of press. It's when the immune system goes a little haywire, a little overactive, and it spits out all of these proteins, these cytokines that cause inflammation. And these cytokines can make you, if it kind of 100% spews out like a tidal wave versus a little bit at a time, you can be very, very sick. And that happens in COVID-19. That also happens to happen in multiple rheumatic diseases. There are many names for cytokine storm syndrome. The other name is called macrophage activation syndrome. And this complication is usually handled by treating or blocking the cytokines that cause it. Now, these anti-cytokines or cytokine blocking agents are actually routinely used in rheumatology. Because one of the nice things that we know in rheumatology is we know in certain illnesses, there are specific cytokines that actually cause as the root cause of some of these illnesses. And by blocking these cytokines, you can actually get rid of the symptoms and get rid of the arthritis. One of the most important cytokines is IL-6. And I'm saying this because this is the cytokine that's important in many people with severe COVID-19 and also in cytokine storm syndrome. So in people with severe COVID-19, they need to block this IL-6 with a drug. This drug is also used in many people with arthritis, especially a very severe form of arthritis called systemic arthritis. And this drug is used routinely. It's given, could be given once a week, be given once every 2 weeks, could be given once every 4 weeks, and it's this drug, this very drug, it's exceedingly expensive, number one, okay, in the tens of thousands of dollars per year. So each dose is pretty darn expensive, and it's incredibly rare because not that many people around the world use it. But when COVID-19 came along and we found out that you need this drug, and this drug works, and it actually treats COVID-19, and then you had millions, tens of millions of people who were really, really severely ill with it. Suddenly, this drug was used for life-saving purposes in COVID-19, and there just wasn't that much around. So this is just one example of the many drugs that we're talking about.
Wow. And then you also mentioned looking at joints through a screen. Like obviously, if I show my joints through a screen, like they don't look swollen. They're probably, even when you reflect a mirror, the reflected screen on Zoom, for example, like everything looks different. It's not as real as we think it is. So I totally understand, like a lot of patients have concerns. Now I have to have virtual appointments. How is my physician actually going to know my foot's hurting or my foot's swollen, but am I going to bring my foot to the screen? It's such a big difference. I know for me personally, like I only had in-person visits throughout the pandemic, which I was really grateful for. But that's because I didn't have to see my rheumatologist as often, whereas some patients have to see them so many times, where when it was really COVID-19 lockdown, we couldn't really go out all the time, right? So I definitely see how that could make such a big difference. And I think even on the physician side, like it might be kind of challenging not being able to communicate properly with your patient.
Yeah, absolutely. I think we take for granted that it's easy to get on the virtual visit. Not everybody has access to stable internet. Not everybody has access to a good camera. Not everybody is as technologically savvy as the people like yourself, Natasha, who do these things. So I think there are challenges. I think for a population of patients and for unique circumstances, the virtual visit is actually really nice. A touch point for a follow-up visit, double checking blood work, having some counseling and a checkup. For the more severe patients, what we're finding is that the virtual visit gives us just a clue. Is it something that we need to see in person, or is it something that's okay virtually? So that many people who need to come in absolutely still come in, because we recognize very quickly on the video that, yeah, this is somebody that needs to come into the hospital so that we can see them right away. The nice thing about the virtual platform, because they're definitely pros, not all cons.
Oh yeah, for sure.
Is a lot of people travel great distances to see rheumatologists because there aren't that many of us. And the nice thing is especially how ubiquitous is it now? You couldn't do it like it wasn't like a snap of a finger. Let's just go on video. You had to pick a platform that's secure, because we're talking about, private things about your health, about your name, about your, things that are very, very private. All of a sudden, with the COVID pandemic, all of these stable private platforms that were rare or difficult to access suddenly became immediately accessible for us, so that we could reach people from far away. So there's definitely a segment of our patient population that really benefited from the technologies that are in place because of the COVID pandemic. So there is a little bit of a silver lining because of that. But you're absolutely right. It just gives us a glimpse into a person. And in the case of kids that need to come in, it's really quite evident right away. And unfortunately, then you have two visits, right? You have a virtual visit, and then it leads to an in-person visit. But nonetheless, important to recognize that.
Yeah, there are a lot of pros and cons, and even gas prices are high. You save gas. There's a lot of concerns. I mean, it doesn't apply to me, for example, but like to my parents, they have to take off of work. Whereas if it's virtual, it could just be me on the phone with my doctor. So there's a lot. It's a big decision. There are also a lot of alternatives if one or the other doesn't work out. Pandemic has really shown us that there's so much more to technology. Even before, we kind of dismissed it, the fact of even using technology, but now we can reach so many people and do so many different things with it. The third point I wanted to bring up from what you said was you mentioned vaccinations. And I think for someone like me, or even any other patient, you hear a lot of physicians saying, if you're on immunosuppressive drugs, skip 1 week after you take your COVID-19 vaccine, or don't. And there's a lot of things on the internet. And I think a lot of people are just confused and concerned at that point. I was like, I didn't know this. Then I had to ask my doctor, and my doctor was like, yeah. Obviously, it depends on case by case as well. But I'd love to hear kind of your thoughts on all of that, because I know a lot of patients were really concerned at that time, like, where do I get my information from? What do I do? Do I skip my medication? Something going to happen to me?
It's a not one size fits all answer. So there's certain medications that you do need to time when your COVID vaccine is, because certain medications, and one example being something that depletes your B cells. So B cells are one of the very important parts of the immune system that make the antibodies, the protective antibodies when you get a vaccine. So some people will get, like, every 6 months, they get this infusion that takes away all their B cells. So the last thing you want is to give a vaccine and then immediately get this infusion, because you'll get rid of all of the B cells that you actually want to do the good work that they need to do, which is make the protective antibodies. So for those, you need to time. The other very important factor is we also have to take into consideration what type of medication and the mechanism that these medications work. For the majority of them, there's really no interruption needed at all for the medication while you're taking the vaccine. And it's really important to remember that, because ultimately we need to be able to balance the risk versus the benefit of the vaccination. So during the pandemic, when the virus was so common, and again, we're talking about various waves and everything, but during the last 2 years, it was basically everywhere, right? So knowing that you can run into the virus everywhere and balancing that with the protective effect of a vaccine, really the vaccination far outweighed any potential of mitigating against using medications. So it's really important to do that. But the one important thing to recognize in people on immunosuppressive agents is the response to the vaccine might not be as good as in people who are not on immunosuppressive agents. So it's not a danger of the vaccine, but it's really whether it's doing all the good that it's supposed to. And that's why the current recommendations are that people who are on immunosuppressive agents, no matter whether you're adults or whether you're children, actually are the priority groups to get vaccination, not just early vaccination, but multiple booster vaccines, because we need to look at that. And in fact, one of the studies that I'm leading right now for the Public Health Agency of Canada is to look at immune response in kids who actually are on immunosuppressive agents or have rheumatic diseases, to see whether the response is the same. Because I'll tell you, all the families, all they want to know, did my child respond well enough to the COVID vaccine? Because there's a degree of comfort knowing that whether you've responded or not to that. So we're undergoing a study right now. It's called Succeed Kids, and it's to basically look at vaccine response to a COVID-19 vaccine in kids with rheumatic diseases. And it's happening all across Canada. Wow. So stay tuned.
Yeah, a lot of people will benefit from even reading what happens with that. In the end, all just depends on you talking to your rheumatologist, talking to your physician. Googling things might not help you. And I think a lot of doctors also recommend Dr. Google. I don't know if should be your best friend.
You know what? Google is great, and it's not great. For COVID, I would say it's absolutely not great, because there is just too much false information out there. And it's really important to talk to the people that are specifically involved in this, to look at your own unique situation. But in general, vaccinations prevent serious illness. Yeah. And when you're on an immunosuppressive agent, your best bet is to give yourself protection against serious illness And that can really, at this point, only come from a vaccine.
Yeah, 100%. I agree with that. And so you do work with Kawasaki disease, and we kind of mentioned that briefly in the beginning of the episode. But COVID-19 has been triggering a lot of cases that look like Kawasaki disease or may, in fact, even be Kawasaki disease. So, how do you actually differentiate between the symptoms of COVID-19 and Kawasaki disease?
This is definitely one of the areas that I'm most passionate about. And there's huge debate in the medical community right now. So, Kawasaki disease is actually just an inflammation of the body. It's actually a hyperinflammatory syndrome. So usually when the body runs into a bug, it could be a bacteria, it could be a virus, it responds by your protective immune response, turning on to get rid of that bug. But in Kawasaki disease and other hyperinflammatory syndromes, the immune system turns on and doesn't turn off. In fact, it hyper turns on. And kids get prolonged fever, they get rashes, they get red eyes, they get swollen red lips and tongue, they get swelling of their joint, their hands and feet, they get rashes and redness, and they get swelling of their lymph nodes. And all of that is really due to inflammation of the blood vessels that supply all of these places. Arthritis is often a component of this, and overactivation of the immune system is a component of this. Now, the most important blood vessels that are affected are actually the blood vessels that supply the heart. So often, the inflammation of those blood vessels, the coronary blood vessels, lead to damage and formation of aneurysms, or these ballooning of the blood vessels around the heart. So it's really kind of scary overactivation of the immune response. Now, the fascinating thing about Kawasaki disease is not one disease. It's actually a syndrome. So you can have a mild case of Kawasaki disease, or you can have a pretty darn severe case of Kawasaki disease, where not only do you get inflammation of the blood vessels, but your heart is inflamed. And when your heart is inflamed, it doesn't pump as well, and your blood pressure goes low, and you get very, very sick. So that's a hypotensive shock, or you drop your blood pressure and you have shock. It's a very, very scary thing. Before the pandemic, a very small proportion of kids actually had the severe form of Kawasaki disease, but we saw it nonetheless. About 2 to 5% of kids that we saw actually got the severe form of Kawasaki syndrome. Now, interestingly, Kawasaki syndrome can be caused by any number of bugs. So along comes SARS-CoV-2, the bug that causes COVID-19. And what happened is kids would get SARS-CoV-2 infection, and they'd only get a mild disease, right? They'd get actually snivels or a sore throat. Often they wouldn't even get a fever, and they're completely fine. But their whole family, at least the adults, probably got a worse case of the disease, and they were sick. The adults were sick. Everybody knew they had COVID. And about a month later, they developed, for all intents and purposes, something that looks like Kawasaki disease. So perfectly healthy, and then a month later, they'd get prolonged fever. They'd get these red eyes, red lips, swollen glands. They'd get rash. They'd get, and then inflammation of their heart and their blood vessels. So looking exactly like Kawasaki disease, and many of them develop this low blood pressure or shock because this virus that causes COVID-19 just happens to be the type of virus that causes this type of shock or extreme version of Kawasaki disease and this cytokine storm syndrome, something that we saw also even before COVID, we saw in Kawasaki disease. So it's this, whether you call it, it's not acute COVID, it's post-COVID hyperinflammation, and it's really Kawasaki disease. The name that people have given it is called multi-system inflammatory syndrome of childhood, or MIS-C, and it really is that whole Kawasaki disease spectrum. But the way to think about it, it's really not the name that defines the disease, it's really what's happening underneath. And what's happening underneath is this: after you get an infection, your immune system goes haywire and it causes hyperinflammation. So hyperinflammation is the underlying cause.
So in terms of MIS-C, I've also heard that there was like an adult version of it. Can you talk a little bit more about that?
Sure. I think what's really fascinating is SARS-CoV-2 or COVID doesn't distinguish between whether you're young or old, right?
Yeah.
Interestingly, when you're under a certain age, we call it MIS-C for multi-system inflammatory syndrome of childhood. And when you're over a certain age, we call it MIS-A for multisystem inflammatory syndrome of adults.
Oh,
So really, humans, doctors or scientists trying to give a name to categorize it so that if you're over, in some definitions, when you're over 21, we give it the A ending. If you're under 21, we give the C ending. In other definitions, we might choose 18. And it all depends on where you live, which country you live, or which organization made the name. So I think it's a man-made distinction right now.
okay.
It's the same thing, okay? It's basically this bug causing hyperinflammation after you get it, but something unique about kids in that you just see it a whole lot more in kids than you do in adults. And it's very much rarer in adults, although definitely seen in younger adults and not really older adults. So exactly like Kawasaki disease. Kawasaki disease mainly affects children, but does it affect adults? Absolutely. But we don't give it another name when it's in adults, right? You still call it Kawasaki disease. So I think a lot of this is people trying their best to understand this disease, suddenly having millions of people across the globe getting it and seeing tons of it. So it's people trying to understand it, but unfortunately giving it weird names and arbitrary definitions when it's just all hyperinflammation.
Yeah, thank you for explaining that. I was actually doing research on MIS-C, and that's why I saw the adult version. I was like, I feel like people might be confused on like the naming, or does that become completely different in terms of symptoms? But it's good that you addressed that. And the other thing I wanted to bring up was still on the lines of COVID-19 and Kawasaki disease. How do you differentiate which is what? Doesn't that get really confusing?
It's a great question. I think they're one and the same thing. MIS-C is just Kawasaki disease caused by SARS-CoV-2 virus. So it's a kind of the extreme sickest kids with Kawasaki disease have the MIS-C phenotype, but there's also kids with MIS-C that look exactly like Kawasaki disease. And if there was only a diagnostic test that we can say, this test says you have this test you have that, we don't, unfortunately. So it's going. There's still going to be lots of people arguing. Potato.
Yeah.
It's really a potato argument. It's the same thing pathogenically.
Okay, good to know. So let's talk about research and initiatives. I know that you are involved in so many, and I think that's kind of how I heard your name even further. And a lot of people kind of bringing me back to Dr. Young. Dr. Young, you have to talk to Dr. Young. So here we are today. I guess let's start with, what initiatives have you created involving rheumatic diseases?
Okay, so thanks a lot for asking that, because that's exactly, that's what I love to do. Is I love to do research so that we can just figure out some answers and improve the care of kids and families who have rheumatic diseases. And because my interest and my passion and my expertise lay in the biology of disease, it was really important that no matter what we did it the same around the world. There aren't that many people who do research in rheumatic diseases, and even less who do bench research, things that basically look at cells or look at proteins and look at genes and look at precision medicine. So one of the first things we did about 10 years ago was gather the flock, as they say, to agree, so that however we measured something in the lab, let's measure it the same way. However we collected blood from our patients, let's collect it the same way. Because the last thing you want is to collect things differently so that you actually cannot be comparing apples to apples. When you're comparing apples to oranges, you're not asking the right question. What you need to do is be able to collaborate. So without collaborating, especially because we're dealing with such rare diseases in rheumatology, we would never make any headway or make any improvements in our patients' outcomes. So in order to collaborate, we have to collect things the same way, we have to measure things the same way, and we have to do all of that. And we have to agree to collaborate and not compete, because there's so few of us who are doing that. So we started a network 10 years ago called UCAN, or Understanding Childhood Arthritis Network. And when I started this initiative, the whole concept was this, that we want to collaborate and we want to do things the same way so that we can just make sure that we can combine our research efforts so that we don't have to reinvent the wheel and we can work together. And what started out as 6 countries, so it was Canada in the lead, myself leading it with support from our governmental peer-reviewed funding agencies, so CIHR and some Ministry of Health in Ontario, as well as the Canadian Arthritis Network. We partnered with our Dutch colleagues, our Italian colleagues, our US colleagues, our German colleagues, and very rapidly recognized that this small nidus of people coming together were really, really galvanized to do things together. And from that small start of just a few countries together, we grew now to really represent over 50 countries and over 300 sites. And almost every single rheumatology organization around the world has endorsed our efforts, so that we are now working together. We all got together and we signed a declaration. It's called the London Declaration because we did it in London in the UK, where we agreed that when we're doing this type of precision medicine work, that we will agree to work together, that we won't invent the wheel, that we'll speed each other's research along, and that we'll be able to help each other in all of our initiatives together. I'm incredibly proud of all the people who have worked on this, and just the incredible camaraderie of our pediatric rheumatology community around the world to come together and work together to speed research along.
Yeah, I talked to Dr. Yost, and if anyone wants to watch that episode, feel free to check that out as well. And we kind of talked all about Can Do. That was really interesting, hearing a perspective from Netherlands and seeing how is pediatric rheumatology over there, and just seeing kind of the commonalities of what goes on here and there. I think most people think the other side of the world is completely different. And that might be for some clinics and some conditions and some doctors over there. But just talking to him was really, really interesting. Like I could go on for hours and hours on how the healthcare system works in Netherlands. And it's really similar to here. So that was a good thing to know and interesting for me to even know about. And I think for other people as well. And so we talked about UCAN. So there's UCAN Cure and UCAN Can Do. So how do you kind of differentiate what those projects are?
Yeah, so when we picked the moniker, this branding of UCAN, it was really just to talk about the initiative and to bring people together to harmonize and agree to talk together. And then people started doing individual research projects. So UCAN Can Do is one project, and UCAN Cure is another project. But they're like hand in glove. They completely complement each other. So UCAN Can Do, can for Canada and do for the Dutch, is a collaboration between ourselves and our Dutch colleagues. And Dr. Joost Schwartz is one of them. Super nice guy, super smart guy who's engaged in all of this, together with his colleagues, Dr. Nico Wolfrat and Dr. Bas Vastert, are really amazing colleagues in the Netherlands to work with. We are only a team of pediatric rheumatologists that I named, but the really cool thing about UCAN Can Do and UCAN Cure is UCAN Can Do and Cure is multidisciplinary, so that everything we do is integrated, not just this clinical arm, but also an arm in the lab to look at biomarkers and predictions of treatment response, but also the health economic impact that this has on decision-making. Because as we mentioned, all these drugs are exceedingly expensive. And right now, the biggest barrier, at least in North America, is access to these drugs and being able to pay for these drugs, and the government or your insurance agency actually allowing you to use this drug. So making those decisions need to be made together by building a case, a business case for decision makers to be able to do that. So we work very closely with health economists. And then at the end of all of that is also to be able to communicate across the globe and integrate our information and really empower patients and give them a strong voice in this whole process so that we can hear their preferences and their opinions as we go forward, applying these new knowledge. So for that, we built a brand new e-health platform. So really an innovative mobile health network that works very closely with the Center for Global eHealth Innovation with Joe Cafasso and his team to really underpin all of the things that we're developing. So this, together with our team in Calgary, and that's Dr. Susan Bensler, as well as Deborah Marshall, who's our health economist, form really the nidus of the leadership of UCAN Can Do. And UCAN Can Do was the first step into joint Canadian government and Dutch government funding to tackle the question of, can we tell parents and kids when they come to the clinic, can we give them the crystal ball answer most people ask you, well, how will I do in a year from now, 2 years from now? We can't tell them that right now. But we're trying to develop predictors that can actually predict what's going to happen in the future, what disease course our kids going to take. And the second research question that's really important is, when do we start drugs, especially these expensive but really good biologic agents? Now, all good drugs have potential side effects, so not everybody should go on the same drugs. So we want to choose the right drug for the right child to start at the right time. So when to start these biologic agents. And equally important is, when do we stop these drugs? Because as you know, people who have rheumatic diseases, we know that it's really a lifelong process that we're going through. We really don't want to be on these drugs for life, right? We need to know when we can safely stop these drugs without the disease flaring. So these are the important questions that we're asking in UCAN Can Do, followed and partnered with this mobile app to give patients a strong voice in this, as well as the health economic evidence to make these decisions and be able to measure the impact on a cost basis. UCAN Cure is funded by the Canadian government, and it is a huge initiative to actually make the decisions or the lessons that we've learned in UCAN Can Do and make them actually happen. So you need to recognize that. So that's one big arm of it. It is 100% complementary. So the patients that we're recruiting into UCAN Can Do are equally recruited into UCAN Cure, but it's the information that's being generated in UCAN Can Do. We'd like to take that information and take an even deeper dive. So the things that you asked about genetic testing, we have deep genetic testing and functional testing in UCAN Cure. And more importantly, we also have an important component where we engage the decision makers. So people at all levels of government, as well as in insurance, are actually engaged in UCAN Cure, so that we can actually then present the information to them and effect actually a change at the kind of working level and go there. So the two grants are very hand in hand and work beautifully together, so that we can, whatever we find, we can speed that to the bedside. Because as we talked earlier in the podcast, sometimes doing the research doesn't mean that you can have it in the clinic right away. And part of UCAN Cure is that translation to the bedside, turning a research test into something that can be done in the clinic right away. And that process often takes a lot of effort, and UCAN Cure has a focus to be able to do that.
Wow, you're doing so much. And there's a lot of people also doing so much to kind of contribute to this. And even, I know, like, I worked with the eHealth Innovation Department last summer, and even as a patient looking at everything that's happening, like, I can definitely tell patients out there that there's a lot of research being done, a lot of people that are kind of collaborating to make the future of rheumatic diseases and arthritis so much better. A lot of people kind of just hear doctors say, oh, research, coming from patients, it's fascinating. And it was really fun even working with them and looking at some of the technology and platforms that are being created for arthritis and rheumatic diseases and childhood arthritis. You've published a lot of research articles over many years. Can you briefly explain something that really stood out to you when writing and publishing a paper with colleagues?
So one of the reasons we publish articles is so we can share knowledge. So it's the one way that we share what we've learned so that people can build on it. Some smart people in the past always say, I can see further because of standing on the shoulders of giants, right? So there are people way smarter than me and other people involved in UCAN right now. And what you want is for them to be able to stand on the work that you've done, recognize the work that you've done, and then make even better discoveries. And I think that's really, really important. So that's one of the main reasons why we have to publish, write papers and do our work and publish it and share it at conferences and all of those different things, so others can build on it and make even better discoveries. So I think that's one of the most important things. I think writing papers is exciting because one of the very important things about writing papers is you have to actually teach your students, your trainees, to write a paper. So most of the times, writing a paper doesn't just engage the collaborators that you're working with in the Netherlands or in Germany or in Sweden and other places, but it actually engages your students. And your students get exposed to all of these people. And it's a really important learning process to learn how to write a paper, to learn how to talk to other people, to accept constructive criticism about how to write things and how not to write things. So I think there's an incredible learning process in both writing as well as publishing the paper. And in terms of the papers, there are many, many different papers that we've been engaged in, some that are purely clinical, some that are purely basic science. So looking at the mechanisms of what molecule does what and what gene does what. The ones that I find most exciting for me are the ones that span the basic research in the lab and have a lesson that we can turn into the bedside. And hopefully that lesson turns into a clinical trial. Is there something that can happen that we can block that pathway that you've discovered? So for me, I think the most exciting thing is the type of discovery that goes all the way from that cell or that molecule in the lab, all the way to your patient at the bedside, and then learning something from the patient at the bedside, going all the way back to the lab, and then having somebody say, hey, I have a drug that can block that pathway. Let's see if that works to make patients better, and then going all the way to test that drug. So it's a very rewarding type of experience and tons to learn during this pathway.
Yeah, I can see how it would be also really exciting. Like you mentioned, it's really rewarding, but also seeing that kind of come into play. You've worked so hard on doing these research. Now you're actually publishing a paper, and seeing that actually into something in the clinical setting is so exciting. I've kind of gotten involved in COVID N group at McMaster University, and where we actually got to publish some papers, and there you get patient partners involved and like knowledge translation. And that's how you get some of that information out there to patients so they can actually understand and read it. Because if we just see a research paper right off the bat, it looks so complicated and confusing to someone who doesn't know even basic science. Using the power of knowledge translation and getting partners on board on research studies are also really important. And so I'm wondering if you or your teams have ever done that.
So critically important question and comment, in fact, very insightful comment, is that, and I would echo that, not just at the end in the knowledge translation piece. The end is really important because you need to make it relatable and understandable, but even at the very beginning. So I can tell you for our UCAN project, at the very beginning, when we started thinking about the UCAN Can Do project, when we started thinking about the UCAN Cure project, we wanted to make sure there was a patient voice. So on both projects, we actually have patient leads who are actually co-investigators on our research teams. And these are people with really lived experiences, either as a parent or as a patient involved in this. So I think the patient voice is so critically important all the way through research, because what I think is an important research question may actually not be that important to the patients that I'm trying to help. I think I'm trying to answer the most important question, but it really is important to get the perspective of the patients in this so that we can really tailor that. Now, the patients might think this is the most important question for me, but it's really a melding and an understanding and a dialogue of all perspectives to be able to understand, why am I interested in this molecule? Because some patients will say, hey, why are we studying a molecule? But ultimately, if I didn't communicate it properly, that this molecule happens to be the thing that causes your joint swelling, and if we can block it, you're going to feel better. And the patient's main concern was pain, and the pain is actually caused by this molecule. What's the scoop? Like it's not going to work. Or if I pick the wrong molecule, this molecule doesn't, do anything other than cause one symptom, which the patient doesn't think is the most important symptom. There may be a host of other molecules we can study, because usually there's a host of them that we're interested in. So this joint discovery, this discussion, this interaction is never unidirectional, needs to go on so that we can really shape the research. And then at the end, as you were just sharing, we need to make it understandable and relevant so that people know what the impact is on their lives and their day-to-day disease management.
Yeah, because I have been a patient partner in multiple research projects. And I think even just coming from a physician saying how valuable patient voices are, it definitely inspires people listening in on today's episode. They can get involved in research, and there is a big part for them to play in research. And thank you for sharing that. So I wanted to kind of end off the podcast with an advice segment. What would you kind of say to those who want to get involved in research?
Go for it. It's almost like a commercial. Just do it. Don't be shy. No matter what stage of learning you are at, you can take part in research. It might be a small part, it might be a big part. But even if you do a small part, the small part is always part of a bigger, more exciting question. If I had to reflect back on my own journey into research, boy, I tried a whole lot of things before I found the thing that really turned me on, right? If there was any, and I share this with all of my students and everybody in my lab, is don't be afraid to try it. No learning is ever wasted. It just tells you maybe that's not what you want to do, but ultimately you're going to find what you want to do. Just be brave, go do it and try it, and you'll find where your passion lies. And when you find where your passion lies, doesn't matter whether you're 6, 16, or 60, you're going to want to keep doing it. And I think that's what you need to do. You need to find something that you want to do when you wake up every day. And I'm really lucky. I found that. I get to do it. I get to live my dream every day.
What direction do you see the field of rheumatology heading in the future?
So I really see precision medicine as a very, very critical part as we go through. Because as you mentioned, right now it's logical trial and error. It's not really trial and error, but it's a logical kind of factual-based trial and error. We want to eliminate that. We want to be able to make informed decisions so that we avoid the trial and error. Because the one thing, especially in rheumatology, that we've recognized is the sooner you can control the inflammation, the sooner you can prevent damage. And preventative medicine, preventing damage is what you want to do so that people can go on and do all the things that they enjoy. So I really think precision medicine, engaging patients to have their voice in the precision medicine. So it's not just choosing the right medicine, but choosing the medicine that works for the patient and the family. All of those are going to be really important things for the future. And I see it as an incredibly bright future. And we're going to need to, with these discoveries of genes and of pathways and of more molecules, we're going to have drugs that are more specific. Right now, our drugs, take steroids, for instance. They work. They're fantastic. But boy, they do way more than what you want it to do, right? They're going to block everything. It works. What you want is a steroid on steroids, right? You want something that's going to be so targeted. It's almost like it's going to be a bullet with your name on it. It's a bullet with the molecule that you want to target, the cell that you want to target. You want it so specific, so precise. It's precision medicine for the person, and it's precision medicine for the disease and the molecule and the cell. That's what's going to be the exciting part of our future. And you can almost see it already. You can see it in the future. It's not that far away.
I'm excited for that. So thank you so much, Dr. Young, for coming on Take a Pain Check today. We really had a great conversation. We were able to kind of explore your passions for research, talk a lot about COVID-19, and then talk more about You Can Do and You Can Cure. Thank you so much for sharing your insights and knowledge. Everyone like, comment, subscribe. I'll link some of those initiatives that Dr. Young is part of in the description. And I'll see everyone in 2 weeks on Take a Pain Check. Thank you. Bye.
Bye.
I can't hide, 'cause growing pains are keeping me